A very warm welcome to Onco Forum 2025 Day 3rd. We are honored to have you join us for this two-day event. We look forward to insightful discussion and meaningful learning this evening. With immense pleasure, I would like to invite Program Convener Dr. Asim Samar. He is a Senior Consultant Medical Oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. It's over to you, sir.
Thank you. Thank you, Team Horizon, for this organizing Onco Forum meeting. And very warm welcome to our uh, what you call is audience and listeners who has joined. And we will be discussing today in depth about the lung cancer. Only one topic we will touch is the lung cancer in and out, and it will be from the perioperative period to post-operative period, role of radiation and role of immunotherapy in focus. So it is a very specific and focused discussion about the lung cancer, so that we can update ourselves and we can impart our knowledge to our patient, so that there will be good service to the patient. And various topics we have covered, and very recent and very, you can say, the practice changing topics we have included in our discussion. It takes a lot of effort about the making the agenda and all that, and I outrightly thank to our speakers and panelists who has accepted our invitation and ready to participate in this discussion and meeting. So first of all, we will start with our speaker, Dr. Virendra Tiwari. He is from Mumbai, and he will be speaking about the pushing the border for resection for end to lung cancer. And we all know every meeting, every discussion, it happens around the end to disease in the lung cancer, because there is a gray zone where you can see that RT plays the role, anesthesia plays the role, and surgery is the prime important thing. So, can anybody who can stop this background noise? It is like WhatsApp is going on now. Yeah, this one. Okay, anyways, you please check it. So, welcome Dr. Virendra Kumar Tiwari, and you have a very good topic to speak about, and I wish we will do the good justice to our topic, and we will be very time bound. So actually, because the other speakers should not wait, and the discussion should be very meaningful, and if we have find place to speak to ask something, we will be having some clarifying point with you. So please, Virendra, you please start, and it's over to you. Thank
Yeah.
you.
Hi everyone, Virendra here. I'm consultant in thoracic surgery in TMH Mumbai. Thank you, Dr. Asim, for this opportunity. So I'll start sharing my screen so that we can begin with presentation without wasting much time.
So every
Is it
time
seen?
we have, yeah, Virendra, every time in the Mumbai when we had a tumor discussion on the Thursday, and lung topic used to come for the discussion, then then after 10 minutes of the discussion, everything goes around the end to disease, and then they
Yeah,
start
yeah.
discussing with the
Yes.
hotspot point and all that. Yeah, so it is still there, I guess.
Yeah, so what Dr. Asim said, it is, still a point of a debate in almost every lung surgery conferences or lung cancer treatment conferences. So why we are discussing even today, because, guidelines are still changing. What was there earlier is now a little bit, there is a change in treatment paradigm. So we'll begin with our presentation. I think he has already pointed out N2 is a very heterogeneous group. There are a lot of different factors that play in treatment of a N2 station, N2 like 3A or 3B. So N2 is different for right-sided tumor and it is different for left-sided tumor. If you see right-sided, your station 7, 4R and 2R becomes N2, whereas for left-sided tumor, it is your 7, 4L, 2L prevascular, and station, that is station 3, 5 and 6, that is pre-aortic and para-aortic, becomes N2. Now, earlier, if you see previous editions of AJCC, it was N2, N3, but now lot is changing, and it is lot is again, going to change. Now it is N2A, N2B, which is single station and multi-station. Even now they are trying to push subset into N2A also, like N2A, if there is a skip metastasis to, because there is N0, though there is no ipsilateral hilar or interlobar node, but only single station N2A, whereas N2A2 will become there is a hilar or interlobar nodes along with the N2 station. So N2A is also going to get divided into N2A1 and N2A2. Why? Because prognosis changes significantly the moment one or other extra nodal station is involved. Till now, recently, we were classifying for the sake of simplicity into early and advanced. Early, whatever is resectable, like discrete nodes, node which is smaller than 3 centimeter, single station, or incidentally detected, whereas advanced were bulky, that is more than 2.5 or 3 centimeter infiltration to adjacent structure or matted adenopathy. So those were planned differently, and surgery was not a part of a treatment protocol in such subset of patient. If you see older database review, almost all N2 single stations were considered for surgery, whereas N2 multi-station, there was a heterogeneous decisions. Few were for surgery, few were for CTRT. And out of all those were considered for surgery, most of them received neoadjuvant downstaging followed by surgery, but most of the patients were considered for definitive chemoradiation. Why then? I think all of us are aware about the Pacific unresectable disease, where you give CTRT followed by durvalumab. There was a significant survival advantage. This is what we took for a multi-station N2 also. That is why multi-station N2 extrapolating from Pacific trial were considered for definitive CTRT. But if you see recent trial, it is like CTRT versus surgery. Now, lot of randomized control phase 2 as well as phase 3 randomized control trial we have seen, which have looked into operable N2. Some of them have included even multi-station N2, especially if you see phase 2 trial by Nadeem phase 2 trial, where almost all patients were N2 and some of them were multi-station N2 also. And what they found out that there is a significant improvement disease-free survival if you give neoadjuvant chemotherapy plus immunotherapy followed by surgery, even in multi-station N2. And if you see follow-up of these trials, like Checkmate 816 presented their long-term follow-up, and what they found out that this PCR that we are achieving with neoadjuvant chemo plus immunotherapy is translating into survival advantage also. So that is a encouraging result. There is a significant betterment in R0 resection. Toxicity is manageable. There is an improvement in DFS, and even OS data is emerging. So everything changed. What earlier we used to sit in MDT, multi-station N2, straightforward take a decision for chemotherapy and radiation therapy. Now there is a debate or there is a discussion. Should we consider surgery in this subset of patient if they are affordable, and if we can give neoadjuvant chemotherapy plus immunotherapy? Now everything is becoming resectable versus unresectable. Unresectable, there is no discussion, alternative management, but in resectable, you can think of neoadjuvant chemo immuno followed by surgery. In stage 3 population alone, if you see, in Nadeem trial, there were 54% of multi-station N2. In Checkmate 816, 36% were multi-station N2. 3-year overall survival in Nadeem trial was 81%, which is significantly better than what we used to get in a earlier database review or retrospective analysis. Now, again, as I have already told you, paradigm of a treatment is changing. It is clearly discussion between resectable versus unresectable. Now, response evaluation is going to become little bit tricky with chemo and immunotherapy, because there is some entity that is called as pseudo progression with neoadjuvant chemo immuno. That is what we have to look into little bit in a better way if we want to plan for a surgery. Another problem is that of these chemotherapy and immunotherapy trial is that 20% of patients could not could not come up for surgery. So that was one drawback that was quoted for neoadjuvant chemo immunotherapy. But if you see chemotherapy versus chemo immunotherapy, even in chemotherapy arm, there was an attrition. So this one point we have to look into precautiously, so that we counsel a patient regarding complete flow of a treatment. It is chemo immunotherapy followed by surgery is a complete treatment, so that we can avoid that attrition. Now, pneumonectomy in N2, again, if you see Checkmate 816 trial, what they have seen that even if there was a significantly reduced number of pneumonectomy with chemotherapy and immunotherapy, but even if patient had undergone pneumonectomy in N2 station, survival was better compared to other management. This is another important paper that is yet to come up with it. This was presented recently in ESMO, LungMate 013, where they have looked into unresectable stage 3B and 3C non-small cell lung cancer. Patients were subjected to chemotherapy plus immunotherapy. And what they found out that if patient is turning up to become resectable, they randomize those subset of patient into surgery versus radiotherapy. What they are extrapolating, or what they are saying, is that if patient becomes resectable with your neoadjuvant treatment, and if you can do surgery, the outcome is significantly better compared to radiotherapy. So there is a significant change in the treatment protocol in multistation N2. Even now in unresectable, to begin with unresectable, the idea is to give neoadjuvant chemo immunotherapy, see the response. If they are turning up to become a resectable, that is one of the treatment options. That is, surgery can be a part of treatment in the subset of patients also. So where do we stand? Only problem is that in these subset of trial, there is a significant intensive neoadjuvant protocol, and you expect grade 3 or significant patients who you know who will end up with grade 3 or grade 4 toxicity. There is a 6.4 or around 7% of chances of progression with neoadjuvant protocol, and obviously you expect a difficulty in surgery because they were unresectable to begin with, and obviously financial implication we all are aware of, being in a developing country. So as of now, biopsy proven staged non-small cell lung cancer, multidisciplinary tumor board discussion is very important, and you classify that patient whether that is resectable or unresectable. Before starting any neoadjuvant treatment, NGS is very important, because patients who are turning up to be EGFR or ALK positive, they have other line of management, they may not respond that well to your immunotherapy protocol. So if these markers are negative, even in multistation N2, neoadjuvant chemotherapy plus immunotherapy is a considered treatment option, followed by surgery. Thank you.
Thank you, Dr. Virendra. So may I ask you one question?
Yeah,
Suppose
sure.
you have two patients. One is right side N2 and another is the left side N2. So which patient is difficult to operate?
So left-sided N2 problem is nodal clearance. Why
And vessels
problem
are
of
there.
nodal clearance? Because when you see anatomy, 4L and 2L are over the undersurface of arch aorta. So
Yes,
whatever
yes.
that you do, either you do VATS or you do robotic or you do open surgery, reaching to 2L station or 4L station becomes difficult. But there is another modality how you can clear these nodes.
Yeah.
So we prefer mediastinoscopy. Mediastinoscopy is a instrument where you put a scope in a pretracheal plane so that you can reach 2L and 4L easily. So surgery, what is difficult? I don't think there is any difficulty in operating left-sided tumor compared to right-sided tumor. Problem is with nodal clearance, which you cannot achieve with VATS. So that is why you have to resort to another method, that is mediastinoscopy. With that, you can do mediastinal nodal clearance, and which will give you a almost equivalent result.
So in the practical point of view, you do first mediastinoscopy and do the
So
nodal
practically,
clearance, or you go for the wedge resection or lobectomy.
so in all patient, our protocol in TMH is still to do EBUS for a staging. If EBUS is N0,
Mhm.
still we confirm that EBUS finding with mediastinoscopy. If on during mediastinoscopy, we send all nodes for frozen. If nodes come negative, we proceed with lobectomy. If node comes positive, like it is N2, then we wheel the patient out and they go for neoadjuvant treatment. And if suppose that turns out to be N3, it is non-surgical, they go for chemotherapy radiation. Now, even after chemotherapy for right-sided tumor, there is no restaging mediastinoscopy. We do lobectomy with systematic mediastinal nodal clearance. But for left-sided tumor, even after chemoimmunotherapy, we do mediastinoscopy just for one point, that is nodal clearance is slightly better with mediastinoscopy compared to your surgery.
Okay, so surgical approach is with the thoracostomy and
Most
the
of the
left side
patients we
open.
do uniportal VATS. Some patients are robotic and some patients are open depending upon their T and N stage.
Okay, thank you very much, Dr. Virendra.
Yeah.
And we'll be having some meeting with you in some offline meetings,
Sure.
so it will be great to learn with you.
Yes. Yes.
Thank you very much for
Thank you.
participating with
Thank you.
us. Thank you.
Thank you very much.
Yeah, so now I will call upon the next speaker. He's also from Mumbai, and he was there in when I was there as a resident. So Dr. Anil Tibdewal, he is from TMH Mumbai from the radiation department, and he is a professor there. And he will be speaking about again the same thing. R2 radiation therapy for N2 disease is still a gold standard. So Dr. Anil, most welcome to you.
Yeah, hi Azim. Yeah, it's good to see you.
Yes,
It's
yes.
been a long time, and
Yeah.
yes, we were there. And Asim is a good friend, and yeah, Virendra is also a good friend. And I will talk about N2 disease also, but my perspective will be CTRT is still standard of care. Um,
It's
uh,
kind of the debate actually,
yeah,
Anil.
so it's kind of a debate, but not actually debate because will not be given the time of rebuttal to Dr. Virendra, I guess.
Yes, yes.
So, yeah, Virendra has clearly pointed on and very rightly pointed out that the shift in management of N2 is happening and it is happening for good. It's not that it's not happening for good, it's happening for good. So, because the patients are survival is of the utmost importance, but I will keep the perspective towards the CTRT, and so with that, I'll not go into the details about why, how to prove N2. Dr. Virendra has already covered what is N2. I will just say that all stage 3 disease are not N2 disease. So stage 3 disease also comes out to be N0 and N1 disease. So we have to keep in mind whenever we are reading out the result, as Dr. Virendra has already mentioned, that 40% were N2 or 45% were N2, and the rest of them were maybe N0 or N1. So whatever we are seeing, we have to see the subset analysis, how the N2s are behaving. So, in 2023, NCCN guidelines was suggestive of the definitive chemoradiation therapy followed by durvalumab as a part of N2 node positive disease, the standard of care. In 2024, also definitive concurrent chemoradiation therapy followed by durvalumab or osimertinib is if EGFR is positive was the standard management. And in 2025 August, yeah, till 3 months or so before, is the definitive concurrent chemoradiation therapy followed by durvalumab. But it is going to change, since the long term result of checkmate 816 or keynote 699 is coming. So hopefully it will be very well simplified into N2A1, N2A2 and N2B, and we'll see that. This is the landmark paper, the Pacific trial, which randomized the patient after CTRT to durvalumab and placebo, and the primary endpoint was PFS by BICR, the blinded independent central review, and the overall survival. What we saw as a long-term result in this population also, this was classified according to the 7th edition, and in this 3A disease were all N2 disease and 3B were N3 disease. And the 5-year overall survival, we all know that it is touching 43%, irrespective of the PDL1 status. And if the PDL1 was more than 50% or more than 25%, the overall survival rate were closely reaching up to the 60% mark, the 5-year overall survival. And after that, you have EGFR
Hello,
positive
sir.
patient. Yes, I'm audible. I guess yes. So in EGFR positive patient, after the completion of CTRT, you can opt for the osimertinib drug, and the median PFS in the osimertinib arm was approximately 3 years, and the overall survival was 3-year overall survival was 84% versus 74%, and here the crossover was allowed in the placebo arm. So after the progression happened in the placebo arm, the crossover was allowed, and the patient still received the osimertinib. And here I would like to highlight that the lung and the lymph node recurrence rate in the osimertinib arm was only 7% after the completion of CTRT and osimertinib. So the loco-regional recurrence was less in the LAURA trial. Now, coming to the head-on trial with the chemoradiation therapy followed by surgery, pre-immunotherapy era, we have 3 or 4 trials which suggest that the surgery or the chemoradiation therapy are more or less equivalent in terms of the overall survival. So this is the RTOG 8901 trial, which suggested that median overall survival is more or less the same. Here, the EOTC trial, it also shows that the 5-year overall survival is more or less 15 to 15% in both the arms. So here also the surgery or CTRT remains more or less the same as that of the in stage 3A N2 population. Here is the famous Kathy Elben trial where N2 single station has come out, and it has shown that if you do N2 single station is one of the important predictor factor for overall survival. But there was no comparison between the surgery and the CTRT only for single station. It was for all N2 disease. But on a subset analysis, they have shown that in a multivariate analysis, they have shown that if you do for a single station lobectomy, it is better as compared to multi-station. Now coming to the neoadjuvant immunotherapy, as Dr. Virendra has already mentioned, this is the Checkmate 816, very famous trial and a very good trial. And it has shown that the pathological complete response rate is close to 24%, and the median overall survival is much better as compared to the placebo arm. What I wanted to highlight here is in the green is that if you see the confidence interval of the entire first plot is the 0.30 to 1.01, so 1.07. So that means it was crossing the unity. Now the 5-year oral survival is better. 5-year oral survival is close to 65% versus 55 versus 55%. And if you see the stage 3A, that is the N2 disease, most likely the N2 disease in this particular patient population, it is also crossing the line of unity. Now, this is the Keynote 671 trial. It also shows stage 3B according to the 8th edition. And here, approximately 15% of the patient were of stage 3B, that is the multi-station N2, and stage 3A, that is approximately 55% of the patient. Here, they have given the pembrolizumab followed by the surgery and then adjuvant pembrolizumab. What I wanted to highlight here is that the 2-year overall survival is more or less the same. But if you see the mortality of the 90-day, it was much higher, or it was double, 1.6% versus the 4%. In numerical term, it is less. It is less like 4%, but 4% is much more when you see a patient individually. And they showed that the overall survival did not differ significantly between the group in this analysis. However, the 3-year overall survival was 71% versus 64%, and the hazard ratio was 0.72. Now, this is the perioperative durvalumab, that the AGN trial. Here also they have taken according to the 8th edition stage 3B N2. Here also you can see the stage 3B, which is the N2 disease. Here it is crossing the unity line as far as the neoadjuvant immunotherapy. That does not mean that there is no evidence here that they are not comparing the chemoradiation therapy versus surgery. They are just comparing chemotherapy, neoadjuvant chemotherapy versus immunotherapy. So the role of immunotherapy is being questioned here and not the role of the surgery here. But what I wanted to highlight, as Dr. Virendra has already mentioned, that approximately only 80% of the patient underwent the surgery. And out of that, so whenever the patient had underwent surgery, the R0 recession was 94%. Approximately 30% patient had no surgery or R plus recession, which was more or less comparable in the chemotherapy arm. So whenever you see the stage 3A or B N2 disease, you need to understand that it's a local disease plus a systemic disease, and we need to start the local therapy as early as possible as compared to delaying it. So the surgery details here, just the highlight that approximately 78% or 80% or 90% underwent R0 recession. So approximately 10% of the patient, 5 to 10% of patients are not able to get the R0 recession, apart from the fact that 20% did not come up for surgery only. And this is the type of surgery comparison. We know that the pneumonectomy patients are also surviving. Previously, also pneumonectomy patients were surviving. But the point of to note here is that why do we need pneumonectomy when we can preserve an organ? That's the left entire lung or the right lung. Whenever you have an equivalent choice or the standard treatment of the CTRT followed by durvalumab, then why do you need pneumonectomy? Because we know that pneumonectomy is the removal of the entire lung. It creates a very imbalance between the physiology of the patient. So we need to be very cautious. If you have a disease which can be still can be treated without an immunotherapy, I would suggest that the chemoradiation therapy followed by durvalumab should be the standard treatment. And then loco-regional recurrences. Checkmate 816 also shows that approximately 25% of the patient had a loco-regional recurrences. Yeah, in chemotherapy arm also had approximately 30% of the recurrences. Slightly shifting onto the adjuvant immunotherapy when the surgery has happened and you are given the adjuvant immunotherapy, I wanted to highlight here is that you see the loco-regional recurrence rate approximately 50%. We have achieved to reduce the rate of the distant metastasis, but by doing the surgery in this particular group of patients, we are exposing them to have a higher risk of loco-regional recurrences as compared to no surgery or maybe chemoradiation therapy followed by immunotherapy or maybe by osimertinib. And there's a lot of debate about the resectable non-small cell lung cancer. There's still debate is ongoing. We can see various papers so which have shown that N2 multistation there is no agreement. N2 bulky is unresectable, and if you are having a T4 N2 multistation, it is also unresectable. So there is a lot of debate about N2 resectable. So it should be discussed in a multidisciplinary clinic, and henceforth. And this is the Asian Thoracic Oncology Group, so which also shows that multi-level station becomes unresectable. So we have to see what is resectable and what is unresectable. There is a lot of scope for the neoadjuvant radiation therapy, as Dr. Virendra has mentioned that. Uh, so, for example, if you can achieve the pathological complete response rate, it can add up to the overall survival. So, there is a role for neoadjuvant radiation therapy also. Here also, if you give neoadjuvant radiation therapy, so before surgery, you can see the R0 rate has increased and R1 and R2 rate has come down as compared to only neoadjuvant chemotherapy. So there might be a potential role for the neoadjuvant radiation therapy, but we will have to explore that in the future. I'll not go into the detail, but this is an important paper which has shown that if you give the SBRT to the primary only and not the nodal station, you can achieve a maximum pathological response rate of approximately 53% as compared to only durvalumab without SBRT. So my take-home messages so will be for N2 disease. N2 remains a controversial area regarding the best line of management. Previous head-on randomized control trial between surgery and CTRT showed the similar efficacy. However, the recent trials with immunotherapy has shown a good result, but there are still no head-to-head comparison between surgery or the chemoradiation therapy. One-fourth patient would have better treated with upfront chemoradiation therapy in all the neoadjuvant immune checkpoint inhibitor trial. So maybe we need to select our patient very effectively so that we don't delay the loco-regional treatment as compared to the CTRT or the neoadjuvant chemotherapy or immunotherapy followed by surgery. Few phase 2 trials with induction radioimmunotherapy have shown promising outcome, and maybe in those 25% of the patient where we are not able to go ahead with the surgery, maybe we can incorporate the neoadjuvant radioimmunotherapy, and maybe the patient can go for surgery and attain a longer overall survival as an outcome measure. And multidisciplinary management remains the key. Thank you very much.
Thank you, Dr. Anil, for your insightful talk. So, most of the time we discuss in our MDT also is this N2 disease. So, many a time surgeon says like if you give CTRT, any CTRT, then they have some difficulty in surgery. So, is this technical or is this some post treatment reaction of the tissue? Like
Uh,
there is fibrosis or there is tightening of the tissue or less vascular supply.
So I
What is
think the
the
technology has evolved from the radiation point of view also and from the surgical point of view also. We have the minimal invasive surgery. Previously, we used to have a lot of open surgeries, and previously the doses were higher. Previously, they used to continue with the chemoradiation therapy and then followed by surgery. But nowadays, what happens is that with a very more precise radiation therapy, I will not say we do have an experience of those particular cases because we do not routinely practice neoadjuvant radiation therapy before surgery. But yes, if I can extrapolate from the esophagus thing, we do neoadjuvant chemoradiation therapy, and they don't find too much of a problem. And in this particular trial also of the SBRT and durvalumab, they have shown that there are no major intraoperative complication after giving the neoadjuvant radiation and immunotherapy. So maybe we'll have to wait and watch and see how the future evolves as far as the neoadjuvant radiation therapy is concerned.
So your take is like a patient requires pneumonectomy, then we should offer CTRT at least. followed by
Yes.
immunotherapy.
So maybe even if you can classify if there is a resectable end to disease, but it is requiring the patient to sacrifice the entire lung, or one part of the lung, or one lung on each side, then I think the organ preservation is much more important as compared to pneumonectomy, because we know that the pneumonectomy itself is a disease, and majority of the patient cannot have a good quality of life after pneumonectomy, and the patient is still living with one lung. If anything happens with a viral pneumonia or something like that, his or her
Yes,
life
that's
will be
true.
at risk. So we have to see,
That is
whenever we are achieving a long-term survivor, we have to see or we have to foresee the complication associated with the treatment also.
Yeah, and organ preservation is also good. Many a times it is good, right? Yeah, thank you, Dr. Anil. So, may I request you to stay for 10, 14, 10, 15 minutes more,
Sure,
because
I'll be there.
yeah, we require you as a panelist in the panel discussion. So next, I would request Dr. Rajit Chana. So Dr. Rajit will be moderating the session. Hello, Dr. Rajit.
Hi, sir.
Yeah, so interestingly, we had listened about role of the surgery in N2 disease, role of the RT in the N2 disease, and now Rajit will be speaking or moderating up with the topic of perioperative immunotherapy of lung cancer in the lung cancer. So you please invite your panelists. I guess Dr. Rahul Rai is not available, and Dr. Sachin. So we'll see. Dr.
Sachin
Anil
is
will join,
not available.
I guess.
So
Yes, whosoever is available, we will go with them.
okay. So Dr. Akansha Chabra, she's there, right? Akansha is there, I guess.
Hi, sir. Good evening.
Right.
Good evening.
Dr. Rahul Rai is not here.
He will join. He will join in between.
Dr. Abhishek,
Hello, good evening, sir.
Yeah,
I am
Abhishek
here.
is there.
Dr. Sachin,
Yeah, he will be joining later.
Dr. Anu.
Yeah, he is not picking up.
Okay.
Anyway, Dr. Vijay Bhargav is there and Dr. Anil Timlewal is there.
Dr. Vijay Bhargav is there, Dr. Anil is there. Okay, so maybe you can share the slide. So to begin with, since there is no surgeon, so I'll ask with all my panelists. So, how many patients of early resectable lung cancer do you see in your clinical practice? Maybe I'll start with Akansha. So, in the last 6 months, how many resectable lung cancer you have seen?
Sir, mostly in my setting, the patients, when they present to us, they present to us in the advanced stage. I would say around 70% of the patients, they present to me, at least in the OPD, in the advanced stage.
So, 30% you have patients who are resectable.
30% of the patients overall, if we discuss in the tumor board, they are resectable. But in my OPD, if you say around 80 to 90, they are unresectable.
Okay. Dr. Vijay, same question.
Sir, I think, sir, I don't think
Your voice is not coming. Okay, so maybe I'll move to Dr. Abhishek.
Yes, sir. Thank you, sir.
The
Sir,
incidence of early resectable lung cancer.
sir, I have not seen any case in last 6 months, and I feel it's less than one. I think 1 or 2% patient. Hardly in a year or two we see one case. Mostly the patients are stage 3 and 4, sir.
Okay. So I think yes, so it is high time that we start detecting early lung cancer. Now there is so much data. So Dr. Anil, so are you convinced? So you had done a very nice presentation. So are you convinced with the perioperative data of immunochemotherapy? So would you refer all these patients to medical oncologist?
Yes, as far as the immunotherapy is concerned, the perioperative immunotherapy, it's a good modality and it is improving the survival outcomes. As we know, as far as the systemic therapy is concerned, yes, I feel that in stage 3 disease, especially stage 3 disease, there is a good role of immunotherapy. So we can debate about in the neoadjuvant setting or in the adjuvant setting. I, being a radiation oncologist, I would prefer to give chemoradiation therapy followed by durvalumab, but we can debate on that afterwards.
No, I think we should debate right now only. So which patients you'll refer for definitive CTRT? Now we have data of IO plus chemo, we have Chinese data also, we have osimertinib neoadjuvant data also. So which patients you will not send to the surgeon? You will just send to the medical oncologist in your private OPD or CTRT.
See, what we do in our joint clinic is like our general OPD only. So what we do is that so whenever the primary is resectable, we are giving them the neoadjuvant chemo immunotherapy as a form of low dose as a part of a single arm phase 2 trial. The reason is that many of the patients are not financially able to afford the neoadjuvant immunotherapy. So what sort of patient is the answer is primary resectable with with non-bulky, those who do not have the extranodal extension as part of it, the radiologist is concerned. So only the single station and primary resectable are the ones I would be very comfortable in sending for surgery.
So, sorry, one more question for you. So, suppose the patient, as you discussed, it is an area of controversy, multi-station N2.
Yes.
So, one scenario patient can afford immunotherapy, second patient cannot afford immunotherapy and is EGFR positive. So, what would be your approach? So, I know there is no right answer, but
I'll give CTRT followed by osimertinib if the patient is EGFR positive.
okay. And if the patient is EGFR negative and can afford immunotherapy,
I'll prefer Pacific trial.
you will again offer CTRT for these patients.
Yes, for multi-station N2.
Yes, multi-station.
Yes,
Okay.
yes.
So, any medical oncologist would like to differ, Dr. Akansha, would you like to take this question for multi-station N2 with no actionable mutation? So, what would be your approach?
Sir, usually we have a tumor board at the upfront, and in multi-station N2
So,
we
this is a
usually
tumor
go
board
with the
only.
CT.
So,
Yeah,
you
so
have a
in
radiation oncologist, yes.
in multi-station N2 we usually offer CT-RT to the patient.
सर्जन बोलता है मैं कर सकता हूँ अगर थोड़ा छोटा हो जाए ऑपरेट तो फिर CTRT करो. You would not give immunotherapy, chemotherapy.
इसमें डाल देना बस.
Usually in our setup, sir, we go for
आपको में डाल दे
CT-RT.
ये 1.5 मिनट के
So
लिए फिर
in
बाद
your
में देंगे.
practice,
उसका
so keeping financial aside, so what is your approach in perioperative? So you prefer neoadjuvant approach, you prefer adjuvant approach?
Definitely, sir. I go with the EGFR, ALK, and PD-L1 testing upfront, and if the patient is affording, I go with the neoadjuvant chemo plus immuno, followed by surgery.
Okay. So Dr. Abhishek, so any patient you will directly go for surgery without offering neoadjuvant treatment?
Sir, I think if localized less than 4 centimeter, in those cases we can consider. Otherwise, 1B onwards, I would go for perioperative therapy.
So what test you do upfront before planning chemotherapy for the in the early lung cancer patients? So
Sir,
apart from PET scan, MRI, what all molecular tests that you done?
sir, NGS and PDL1, sir.
So you how much time does NGS takes at your center?
Sir, it takes around 7 to 10 days, sir.
So you start treatment after 7 to 10 days. How do you approach? So you wait for the NGS to start treatment, or you start first cycle
Sir, first
chemotherapy?
cycle in we give first cycle, and if there is a molecular alteration, then we change it. But we don't wait for NGS, sir. Proceed
So
with the chemo.
suppose there is the patient turns out to be EGFR positive after 7 days, then what would be your treatment approach? You will continue with chemotherapy?
Yes, sir. Yes, sir. We can add OC in neoadjuvant along with the chemo, and then we can continue it post surgery also.
So you are convinced with the new EDORA data which has just come up, so you'll use that in your clinical practice.
Yes, sir. Yes, sir. It shows a good result. I mean, survival was there.
Good. So it has, I think, shown only survival data is still not there. It has shown major pathological response. Suppose this patient was ALK positive, then what would be your approach?
In that case, I'll give only chemo, sir, because in ALK there is no, I mean, neoadjuvant data as of now. Only adjuvant is there.
So, Dr. Vijay, so suppose this patient you started on chemotherapy, and after one cycle, patient had ROS1 or ALK1 positive. Then what would be your approach? This patient, mind you, we are discussing resectable lung cancer. Dr. Vijay is not here, so I guess I'm back to Dr. Akansha. So suppose Akansha, the patient turns out to be ALK or ROS positive. Then would you continue chemotherapy? Would you add immuno? Would you add TKI? Would you ask the surgeon कि भाई अब surgery कर दो मैं बाद में देखूंगी?
So, sir, basically, in my practice, I don't go with the NGS upfront. I usually send EGFR, ALK, and PDL1, and I start with the because the results are out whenever we start with the treatment. I start with if these are negative, I start with the neoadjuvant chemo plus immuno. But if the patient comes out to be positive for any driver mutation, I usually omit chemo. I usually omit immunotherapy. I only go with the chemotherapy followed
So
by.
is there any data that only neoadjuvant chemotherapy in resectable lung cancer can lead to a survival benefit?
Sir, the only thing is that whenever there is driver mutation positive, we know that the immunotherapy is not that effective. That is the only reason that I would omit immuno in
So
the.
would it not be, I don't know, would it not be practical to send the patient to surgeon ki you do surgery first?
Sir, usually we all discuss all these cases in the tumor board only, and whenever these reports are out, we again discuss this patient in the tumor board. And if the surgeon says yes that he is operable, we can send the patient to surgery first.
Okay. So I think what I can discuss, what my panelists have suggested, that upfront molecular testing is required. At least EGFR ALK should be done. NGS is also a viable option, and we should wait for the molecular testing report before adding immunotherapy to these patients. And if it turns out to be positive, then if we follow the new ADORA data, which is still not yet approved, we can add osimertinib plus chemo. For other, I think we should discuss with the surgeon that whether surgery is possible if it comes after starting chemotherapy, or we can continue only with chemotherapy. So Dr. Abhishek is there, right? So Dr. Abhishek, so which is your preferred IO of choice? So
Sir, I'll
we
go
have,
for Pembro, sir, because survival data is there. I mean, maturing now. So Nivo and Dua is also there, but Pembro would be my
so
first
what
pick.
what are the surrogate markers apart from finances? What all practical things that you generally consider? So suppose your colleague offers nivolumab and the patient comes from for a second opinion. So would you say that no, Pembro is the best option? So anything, what factors that you consider
I
in
think, sir,
deciding?
in Nivo data, I think it was PATH CR, and but in this Pembro, I think DFS and OS both are, I mean, maturing, sir. So OS benefit would push me to go for Pembro. Other than that, PDL1 status also, sir.
So how would PDL1 status change your decision?
I mean, in Pembro, sir, I think if I'm not wrong, the trial included even less than 1%.
Okay. So what you are saying that this data since had maximum number of patients who were PDL1 negative, so you are more confident in using
Yes, sir.
PEM.
Yes, sir. Yes, sir. And plus, overall survival is, I mean, in
So
all three
this
IO,
survival data is, as far as I know, is there with Checkmate 817, 816. Rest still
816.
not there.
Sir, but recently, just before coming today, I checked it
Okay.
up to date.
So,
And so it has shown that it is maturing and overall survival is there, sir.
okay. So to the organizer, can you just move my slides?
Sir, here I think we have Nivo data overall survival also. It is showing overall survival benefit with Nivo also. This is
Yes,
what.
correct. So, and I just want to show you a table. Next slide. Next slide. Next slide. Please keep on moving. So, Dr. Akansha, I think only Dr. Akansha is there. Dr. Abhishek is there. Dr. Anu is not there. Dr. Rahul is not there. Dr. Sachin is not there. Dr. Vijay is not there. So, I guess only two of you are there. Maybe Dr. Asim can also join. So, Dr. Asim, so what's your take on the adjuvant data that we have? If you are listening, can you move the slides? So Dr. Asim is also not there. So Dr. Akansha, so based on the adjuvant data, so if the patient undergoes upfront surgery, so what factors would you consider in adding adjuvant IO to these patients?
Sir, the only factor that I would consider upfront will be PDL1 positivity. If the patient has not received any immunotherapy upfront, I would like to add atezolizumab in such patients if PDL1 is more than 1%. But if the patient has received neoadjuvant immunotherapy, I prefer nivolumab, which I give only for 3 cycles, and post that I just continue with the surgery and the adjuvant.
Okay, so PDL-1 1 would you take as the cutoff because
I
the,
would,
the
sir.
approval is PDL-1, but the benefit was more in PDL-150, but you will go with the
Yeah,
approval.
yeah. Even in 1% we do consider for ATSO.
Okay, so can you please move the slides? I just want that table to be move the slides. Move the slides, please. Move the slides. Move the slides. Yes, this one. So now that we have data in the adjuvant setting, we have data in the neoadjuvant setting, and we have data of the Chinese immunotherapy, which is also there, like the new torch data. And there is one more data that is there. I think it is the drug is not available. Camilizumab, I'm not sure. So with the availability of the neotorch data, which is toripalimab and rationale 315, which is tislelizumab, and both have shown almost similar major pathological and path-CR response. So would it change in your practice? Would you be counsel you? Would you give these options to your patient? So Dr. Akansha, maybe you can take this question.
Sir, definitely yes, because these data are impressive, and I think tislelizumab is even cheaper than the immunotherapy that we give. In my center, affordability is also a big issue, so I think I would offer that also.
Okay. So one advantage of the Checkmate 816 data is that I feel maybe one of you can take this question. So that there is no data of adjuvant therapy. So we can only give 3 cycles of 360 mg, and patient can be doesn't require any adjuvant treatment. So would that duration of treatment would also make a difference, or would you still offer something if the patient doesn't achieve a PAT-CR in after the Checkmate 816 study? So maybe Dr. Abhishek can take this question.
Yes, sir. Very good point highlighted by you. Only 4 cycles were given and no adjuvant treatment as it was given in Pembro. I mean, 1 year it was given. But most of the patients, even more than 60% patient did not achieve PET-CR. It was around, I think, 24 or 30% only. So
So
in
I
keeping
think in
that,
all these trials it is around 24% only. So none of the trial have shown more than 24, 25. It is anyways between 18 to 24 in all these trials. The
so
PAT-CR.
sir, yes, sir. So keeping that in mind and the curative intent and all that, I would be pushed to give something as adjuvant, sir. So
Okay. And
that will, I
what
mean,
would that be? Pembro or Durva?
sir, sir, I'll go for
Chinese.
Pembro, Pembro, sir.
You are fond of Pembro.
Right.
And Akansha, you will give what? Or you will keep the patient on observation?
Sir, as of now, we don't have data that if we have given perioperative nivolumab, which I usually use because of the cost issues, because only 3 cycles are sufficient. And post that, we should give, but there is no data that we can continue with another immunotherapy if we have not received PCR. So as of
So,
now, I just keep the patient on
so you
follow.
are comfortable if the patient is not in PAT-CR, so you are comfortable keeping these patients under observation, right?
Yes, sir. I usually comfortable to pata nahi, sir, but I usually keep these patients on follow up only based on the data.
Suppose this patient goes to Dr. Vijay and he offers durvalumab. So what will you then ask your patient whether to go with durvalumab or to keep on observation? And because see, this is a clinical scenario that we do face, and I don't think there is a right answer, but it's just that we have to come to a consensus. So probably you will put your patient on observation, right?
Observation as of now, yes, sir.
Okay. And one question to first Dr. Vijay. So how comfortable are your surgeons, when you go and when you give immunotherapy and chemotherapy? So in terms of fibrosis and all those difficulties that they face, so any inputs from the surgeons that they say that surgery is difficult or surgery is very easy after IO?
Good evening, sir. Sorry for the some technical glitch from the my side. Basically, frankly speaking, I don't have a. I have in our center. I have not yet used any new adjuvant immunotherapy in lung cancer, in spite of data, but due to poor availability of eligible patient and availability of surgeon. This is a practical kind of question. So, without any guessing answer, I think that should be with a person who is dealing with neoadjuvant immunotherapy and then discussing with surgeon about that. But definitely in other setting, not in lung, but in other setting, whenever there is a neoadjuvant therapy, surgeons are more comfortable with afferent surgery most of the time. And if disease is locally advanced, then they expect some good response. So though immunotherapy is not so change the fibrosis and all those things as compared to radiation, so I expect that they are comfortable with chemotherapy and immunotherapy in neoadjuvant setting as compared to neoadjuvant radiation.
Okay. So,
Sir.
Dr. Abhishek, would you like to add something? So, any experience of you and your surgeon after neoadjuvant immunochemotherapy?
Sir, one of patient we gave nivolumab last year, and patient had, I mean, he did not achieve PAT CR, and we continued. We did not give adjuvant treatment. Also, he relapsed after. I mean, he had a recurrence after 6 months, and it was metastatic. Is then we started him on IO and gave chemo again. So the patient was 2B to be precise. So my
Okay.
experience with this immunotherapy was that that's why my point came that most of the
So
patients.
then did you repeat the NGS? So
Yes,
maybe.
sir. Yes, sir. Yes, sir. It was negative. Patient was a heavy smoker, and it was negative upfront also and repeat also. It was negative, sir. PDL1 was, I mean, in repeat, it was around 15%, if I'm not wrong. And we continued for almost 6 months. We gave IO plus chemo, and then he progressed later on after 4 cycle. Eventually, he succumbed after almost 9 to 10 months.
Okay. So, okay. So, and how comfortable is your surgeon?
So surgeon was, I mean, no, in our setup, I have not seen anyone doing upfront surgery, but post 4 cycle, after assessing the patient fitness and everything, they were comfortable and they underwent with the surgery.
So I guess it is still evolving and surgeons are also learning, but I believe that most of the surgeons they are, getting more and more comfortable because of the excellent response that this combination is providing. So if Dr. Anil is still there, I would like to ask him one question that is there any role now of adjuvant RT?
Is there any role of?
Adjuvant RT.
I guess no. As far as the two trial, that the lung art trial and the Chinese trial, they both have shown that there is an improvement in the disease-free survival, but there is no improvement in the overall survival. However, at the later part of that particular study, as per the ISLC recommendation, if they had done the nodal staging again, so majority of the patient were having ENE, the extranodal extension. And for that, yeah, but some oncologists do advocate the use of post-operative radiation therapy, but not to all patients. So we have to see individually,
So
but not.
anything, so any margin positive, any indication of
Yeah, so, yeah, the margin positive R1 or R2 recession, yes, definitely the post-operative.
R0, the data is now very limited, right?
Yeah, for margin positive, so there is a paper so which has suggested that adjuvant chemo radiation therapy will be much better as compared to only chemotherapy or only observation. But as far as but the nodal is concerned, the N2 disease, the two recent trial have not shown any improvement in the overall survival, but there was a definite improvement in the disease-free survival.
Okay, thank you. So, Dr. Akansha, so do you think that, like breast cancer, HER2 positive breast cancer, now the treatment approaches in lung would be similar to what we do in breast cancer? So, like neoadjuvant chemo, and then are you convinced with the surrogate marker of pathological response and major pathological response in lung cancer? So, do you
Dr.
believe
Rajit
that it
sir?
corresponds to the OS?
Yes, sir. So basically now we have the data in breast already that the
Excuse me,
PCR can.
Dr. Rajit sir. Sorry to interrupt you. We
हाँ बस
request you
खत्म
to
कर दूंगा
please conclude, sir.
हाँ
So
लास्ट स्लाइड कर दोगे वाली स्लाइड की
we have data in breast that PCR can lead to better overall survival. So yes, I am convinced that in lung cancer also with neoadjuvant approaches with immunotherapy, it would lead to PCR would lead to better overall survival, which we have already seen with Checkmate 816.
yes so I think probably yes in near future in upcoming times we'll do see more and more of new adjuvant in lung cancer. So any last words from Dr. Abhishek, Dr. Vijay, Dr. Anil?
So I think we should use more and more IO in perioperative.
Correct. So I think that this is more important that we get the find the appropriate patient and do the necessary test upfront. PDL1 doesn't make a difference while offering neoadjuvant chemoimmunotherapy. Markers definitely make a difference, and we do have very convincing data in the neoadjuvant setting. Various combinations are available, even Chinese IO are available. And in adjuvant setting, we can always personalize the treatment option for our patients. So thank you, my wonderful panelists. Thank you,
Thank you,
Dr.
sir.
Asim, for giving me this chance. Thank you.
Thank you, Dr. Ajit. So thank you very much, and all the panelists. Thanks to you for participation. And Dr. Rajit, one last week we were having the presentation by Dr. Anant Ramaswamy. So he was also was sharing the data about the colon cancer where immunotherapy was used in NSCT setting and neoadjuvant setting, and they are showing wonderful results. Only 2 cycles had a very good CR rates. So maybe
Regardless of PDL1,
yes,
regardless of TMB, MSI.
regardless of that,
Okay.
that was a very good data. So this modality is emerging, but surely, as Dr. Akanksha said, rightly said, this will come up in a very big way that we can see. And the special thing is, if you have a tumor to train the T cell, it will be great. So
Correct.
immune cell always require antigen to
But
train
in
them.
colon, I am not sure because colon immunotherapy has not shown much data.
In
But maybe,
NSCT setting, they are showing some data, and Tata has, I guess, started trial also
wait.
in the neoadjuvant setting. So that will be the same case here also. So thank you very much, all the panelists and Dr. Rajit especially. And now I will invite Dr. Ankur Punia. He is the professor in Mahatma Gandhi Medical College and Research Center, and he will be speaking on leveraging tislelizumab potential in management of the lung cancer. And this session is sponsored by the Glenmark. Over to you, Dr. Ankur.
Yeah, thank you, Dr. Asim. Thank you for inviting me for this. So I'll just share my slides. So are my slides visible?
Yes, Ankur.
Oh. So this is a sponsored session by Glenmark. So basically, I'm going to discuss about the newer immunotherapy which we are getting, tislelizumab, by focusing particularly on the lung cancer. So it's basically a monoclonal antibody, again, specificity for PDN1. It blocks the binding of PDL1 as well as PDL2 to PD1. It's differentiated by binding to different epitopes, had a different kinetics, and different orientation compared to other PD1 inhibitors. Standard dose is used is 200 milligram every 3 weeks, and it has been developed in multiple indications, many solid tumors as well as hematological cancers. There are more than 20 trials which are enabled in multiple countries, and almost 13,000 patients have been dosed in trials, as well almost 750,000 patients have been treated all over the world. So these are the global indications and development for this molecule. It is approved in nasopharyngeal cancer, lung cancer in almost all the settings, first line, second line, squamous cell, non-squamous cell. In India, it's approved in this, as well as it's approved in Europe and China and multiple other countries as well. Similarly, for gastroesophageal cancers, esophageal squamous cell carcinoma, as well as HCC, it's also approved in multiple countries. It's approved in second line urothelial cancer. It's approved in second line MSA high tumors, as well as approved in Hodgkin lymphoma in China. So these were the major global trials. Rational is the trial names which are used with this molecule. So for squamous cell esophageal carcinoma, rational 302 and 306 are the main. I'm going to discuss mainly about lung cancer in this study, in this presentation. But as shown, there are multiple first line global trials has been done in HCC, gastroesophageal junction, as well as lung cancer. So this just highlights the major trials which were done. Multiple trials are there. These non-small cell lung cancer trials I'm going to discuss later. We have a study with in esophageal squamous cell carcinoma in first line as well as second line setting with rational 306, 311. It is also there in the gastroesophageal junction, the rational 305 study. Similarly, as I told, in urothelial cancer, it's approved in the second line setting. For Hodgkin lymphoma, it's approved in China. For HCC, it is being approved in first line as well in second line setting based on the rationale 208 and 301. For MSI high, again in second line post therapy progression, we can use based on the rationale 209. And for nasopharyngeal, rationale 309 in that trial, which shown the benefit in the first line setting. So how it is different from other, PD-1 inhibitors, which we are using for a long time. So basically, tislelizumab has a distinct, binding orientation, and it binds to different epitopes on PD1 as compared to other PD-1 inhibitors like nivolumab or pembrolizumab. And because of its orientation, there are different binding kinetics compared to those other molecules. Binding surface also quite overlaps largely with that of PDL1. So it has a more effective blockade of PD1 and PDL1 interaction, almost more than 99%. And because of that reason, Pembro and Nivo, they don't have that much effective complete blockade, and their blockade range in the around 80% area. So how does basically any monoclonal antibody works? This PD1 is, PD1 expression is induced where T cells are activated and they need PD1 to, interact with the tumor. So when PD1 blockade is there, the T cells don't interact and with the tumor cells, and they don't evade evasion from the immune system. So this is where the anti-PD1 monoclonal antibody works. It comes and block that receptor, so the immune system gets activated and it targets the tumor cell. But what eventually happens with most of the monoclonal antibodies, the natural response of the body is the macrophages, which will eventually phagocytize these antibodies and diminishes the response. So here it makes a big difference because tislelizumab has minimum binding to this FcR receptor, which is responsible for phagocytosis by macrophages and which markedly reduce, which changes the kinetics of this particular molecule. That is why in preclinical models it was shown that it had a high target affinity and slow dissociation, almost 50 to 100 times slower than other PD1. Its half-life is approximately 30 to 80 fold longer than that of other PD1 inhibitors like Pembro and Nivo. And similarly, it has a lower half maximal inhibitory concentration, thus having a stronger, anti-tumor activity. Its IC50 values are almost 1.3 to 3.5 times lower as compared to the other PD1 inhibitors. So all this, preclinical works makes it a more effective PD1 inhibitor compared to pembrolizumab and nivolumab, probably in overcoming many of the shortcomings of those, and many patients who might not be responding might respond better to this molecule. So what is the clinical evidence? So my major focus today is going to be on lung cancer, as such, particularly non-small cell lung cancer. So start with the first rational trial in the squamous cell carcinoma first line setting. Rational 307 is the study which compared tislelizumab along with chemotherapy versus just chemotherapy alone, followed by maintenance therapy. And we look at the PFS, it was statistically significantly increased. In we compare, there were two arms based on different chemotherapy combination, but showed more or less the same difference. PFS was improved. It was 7.7 versus 5.5 months. And for patient who used nab-paclitaxel, it was 9.6 months. So improvement in the PFS. And you look at different subgroup analysis based on this forest plot for PFS. Almost all the patients benefited, irrespective of PDL1 expression, stage, advanced stage, low stage. All the patients had a benefit, irrespective of the chemotherapy backbone. Look at the response rates. Response rates were almost more than 50% increased for immunotherapy combination, almost in the tune of 70 to 75% compared to just 50% alone with chemotherapy. Similarly, we look at the overall survival. It was almost 26 months in the combination arm compared to just 14 months. So again, significantly increased with a good hazard ratio of 0.53. So it makes more or less the standard of care for first line squamous cell carcinoma. So now coming to the rational 304 study, that 307 for squamous cell. Now this is for non-squamous cell first line setting. Again, similar trial design, first line either immunotherapy with chemo or just chemotherapy, followed by maintenance chemo or maintenance chemo plus immunotherapy. PFS, we look at, was again significantly improved, 9.8 versus 7.6 month. Overall survival at two-stage model showed at 22 months versus 15 months, significantly increased. Response rates were also more, almost 58 versus 37%. PFS for patient who are PDL1 more than 50 was 11.5 versus 4.6. And median overall survival was remarkable at 43 months versus just 13 months for patient who are PDL1 high at 50%. So for these patients, a remarkable result with this immunotherapy combination. Now coming to the second line setting, this was the Rational 303 trial in which they compared tislelizumab single agent versus docetaxel as second or third line patients who had progressed on prior therapy. So they were randomized between tislelizumab versus docetaxel. So they included all squamous and non-squamous patients and irrespective of PDL1. So in intention to treat population, overall survival was increased. It was 16.9 versus almost 12 months. And at 2 years, almost 13% more patients were alive on this drug. Similarly, for patients who are PDL1 more than 25%, which was on the stratification factor, OS was again improved. We know that higher the PDL1, more higher the chances of patient responding to immunotherapy and better the survival. So at 2 years for more high PDL1, almost 40% patients were alive and doing well. So it's again a remarkable thing for lung cancer patients. Look at the long-term 5-year overall survival data. At 5 years in intention to treat population, 20% of patients were still alive and on treatment. And if for patients more than 25 PDL1, almost 1/4 of patients were still alive at 5 years, which we don't see at all with chemotherapy. Looking at the subgroup analysis of the overall survival, we see that based on focusing on PDL1, PDL irrespective of PDL1, whether it's less than 1, more than 1, 10, or any cutoff was used, 25, 10, 50%, all the patients benefited. So this drug benefits all the patients irrespective of PDL1, whether low or extremely high. Similarly, we look at all the other, stratification factors, whether the patients had any, baseline pathology was squamous or non-squamous, all the patients benefited, whether it's for second line, third line, brain mets or not, everybody benefited by this combination. So PFS was improved in, intention to treat, it was 4.2 versus 2.6 months. Again, PDL1 high, it was rather more improved, 6.5 versus 2.5 months. Response rates were almost more than tripled for intention to treat. And there were almost 6 times for patients who are PDL1 high, the response rates on tune of 40% in second and third line, which is a remarkable thing. So looking at a biomarker analysis was done for this study, and they've seen a nice thing that for patient with a notch mutation actually did well with this combination. So in the tislelizumab arm for patient who had this notch1 mutations, their overall survival was almost 2 years compared to around 15 months in patient who didn't have notch mutation in the tislelizumab arm. So notch mutation actually showed that a good correlation with the eventual outcome for these patients. Similar thing was seen for progression-free survival, that for patient who had the notch1 mutation, PFS was all tune of 14 months in the immunotherapy arm versus notch wild patient had a PFS of around 4 months. So notch mutations actually, predict a good outcome and response to this immunotherapy. So this was a network meta-analysis which was done to compare tislelizumab versus other immunotherapy combinations which we are using in first or second line setting. So it showed that for progression-free survival, that the tislelizumab and chemotherapy arm was significantly more favorable than either using chemotherapy, nivolumab, nivo plus EP, or atezolizumab plus chemotherapy in the first line setting. Similarly, if you look at the regarding PFS, it was the most efficacious with the best hazard ratio compared to all other immunotherapy or immunochemo combinations. It was the best, most efficacious treatment compared to other immunocombinations for PDL1 more than 50% patients. Again, for in second line setting for any histology, again, it was ranked the most efficacious treatment compared to other single agent immunotherapy or chemotherapy. Tislelizumab was the favored arm. So to basically conclude, it's a highly active and efficacious PD-1 inhibitor. It's monotherapy in second line, in first line squamous or non-squamous or PDL1 more than 50%. It is quite favorable in overall survival, PFS, or regarding adverse events. So some little thing about the neoadjuvant perioperative setting. There is trial rational 315 where it's used in perioperative setting, and it has data is still early, but it is showing favorable event-free survival. OS is still awaited. Similarly, for extensive stage small cell lung carcinoma, again in first line setting, it has shown an overall survival benefit. So again, it can be used in extensive small cell lung cancer as well. So coming last to the adverse events, you look at the adverse events again, different immunotherapy trials, we can see they were more or less similar. What was seen in the different immunotherapy combination, and nothing new was seen. So it's quite favorable, and more or less we see what we are already seeing with the using other immunotherapy combination. And there was no, even that meta-analysis, there was no any difference compared to other immunotherapy combination, more grade 3 or more adverse events. Similarly, there was a statistically significant reduction in risk of experiencing, grade 3 adverse event compared with atezolizumab or pembrolizumab or chemotherapy based on this meta-analysis in the second line setting. So this, these trials and all more or less, makes it one of the combination which can be used in the first line or the second line setting in the lung cancers. And now it has come up in perioperative as well as in extensive stage small cell lung cancer as well. Thank you.
Thank you, Dr. Anko. So I must share the data. We have started in 4 patients till this date. Side effect we have not seen, but patients are due for their response assessment. But early results which we could predict is they have good symptomatic relief with this drug. So maybe this drug is effective, and the international data are saying the same thing. So that will be a good option to include in our treatment paradigm. So my one question is to you: where do you find this drug is suitable in your clinical practice, especially in anesthesia setting?
So I think that just the, just a habit of what I will feel. We are used to, prescribing other immunotherapies. It's a newer
Yes, yes.
immunotherapy. And it is one of the immunotherapy newer which we are getting from China, which is have the most global trials, the most, global approvals are there for this immunotherapy. And it has been there for a long, long time. One of the, I will say the earliest immunotherapy developed by China. And we have good enough evidence. So yes, I will be happy to use for any patient who is eligible for immunotherapy and who can take the immunotherapy in the lung cancer patient, bar it in an early or advanced setting.
And the cost factor is also very convincing actually. So cost is around
Yeah, that is
62,000 per dose.
so that is the biggest factor for us. So yes,
Yes,
for
yes.
patients who buying from pocket or a PPA, it's the best option for them.
And even for RGHS. So our hospital is favoredly giving approval to this drug, because sometimes if happens like their money is stuck with the government institution, then they will be at the less loss actually. So this is the two good
Yeah.
thing, but cost is actually prime important thing. And esophageal cancer also they are saying good results. Small cell also they are saying good results. So we yet to conclude and yet to see the results, but still it is a good option.
Yes.
So thank you, Dr. Ankur, for your nice presentation. Now I will move to the next presentation, which will be done by Dr. Jitendra Kumar Pehlajani, and he is the consultant medical oncologist in the SCG hospital, and he will be speaking on vision for METX 14 skipping patient in NSCLC. So, and this session is sponsored by the Merck. So, Dr. Jitendra Pehlajani, is he there?
Good evening, everyone. Thanks, Asim boss, for the opportunity. So, as we know that MAT is an important marker in the lung space, and precision therapy is the future. Can you share the slides, please?
Sure, sir. Just a second.
So these slides are provided by Merck, and there's a small mistake which I will tell when I will go through the data sets. So this is the vision trial, which was for the TEP-METCO drug, and Avni, next slide.
Excuse me, tech team, you please be attentive to move the slides.
Yeah. So coming to the non-small cell lung cancer, as we all know that there are at least 12 markers which we are NCCN approved and which have targets. So MET is an important target after them, which is 3% and which is easily detectable uh, with the NGS. So molecular testing is important in lung cancer. Next slide. So this is the NCCN guideline which say that MAT exon 14 skipping metastatic NSCLC should be given tapatinib or capmatinib, and in certain circumstances crizotinib has to be given. And ISMO also suggests the same. Although we do see MET amplification in that first line chemotherapy plus minus immunotherapy is required to go. Next slide. So this is the drug tapatinib. It's an oncogenic MET receptor inhibitor, which actually is an ATP competitive reversible type 1b MET inhibitor. It inhibits oncogenic MET receptor signaling, including that caused by oncogenic alteration to the MET gene. And this is the structure of the molecule, and because it is a type 1b inhibitor, these are highly specific for MET with fewer off target effect as compared to other type 1a inhibitor. Next slide. So this is how the MET pathway works. That basically there is a ligand dependent signaling in MET or ligand independent signaling in the MET. In ligand dependent, there is a HGF ligand binding promotes receptor dimerization and activation. In ligand independent, there is increased expression on the cell surface, which lead to increase the tendency for receptor dimerization and activation in the absence of a ligand. So the drug tapatinib inhibits of aberrant MET activation in tumors differently, uh, especially in the MET exon 14 skipping and MET amplification, which leads the tumor cell proliferation, survival, and cell growth. Next slide. So the visions coming to the vision study, it is the largest study, around 300 odd patients. It was the first clinical trial. There were elderly patients, more than 30% patients were more than 70 years of age, and it is line and agnostic, means upfront MET exon 14 mutation as well as mm, second and third line MET mutation patient were taken. Next slide. So this is a advanced metastatic NSCLC which has MET exon 14 skipping mutation, which can be detected by liquid as well as tumor biopsy. There is no primary treatment with therapy and with the MET pathway and less than 2 lines of prior therapy. For cohort A and cohort C, the cohort A was 152 patients and it was upfront, and cohort C was done by confirmatory analysis. So almost these two cohorts were taken in the analysis. 450 mg drug was given, 225 mg, two tablets a day was given. So treatment day was 164 patients, previously treated was 141 patients. The primary endpoint was overall response rate. The secondary endpoint was DOR, PFS, OS, and safety. So if you can see in the treatment day group patient, the age was 74 and previously treated it was 70. Almost half of them were male in the upfront setting, where the patient was good performance status. And on the contrary to the EGFR ALK mutation, half of the patient in this study were having smoking history. Adenocarcinoma was the most common histology, and around 18 to 20% patient did have the brain metastasis. Next slide. So coming to the MET alteration on the basis of tissue biopsy. So out of 159 patients were having liquid biopsy, means out of total population, 36% was proven by the liquid biopsy. 21% had both liquid plus tissue biopsy, and 42% patient had both had only tissue biopsy. Next slide. So coming to the treatment naive patients of cohort, the overall response rate was 56%. 1 second. So overall responses are 58%. Median duration of response, this is probably there is some typing error. I have seen the data says that it's around 18 months. The median PFS was 15.9 months and the median OS was 29.7 months. As we can see in waterfall curve, there were deeper response and there was a large number of patients who had a tumor shrinkage around 90%. And these were tumor were consistently sensitive to the drug tapmetco. Next slide. So coming to the cohort number 2, which is previously treated patient, there were overall response rate was 49.5%. Median duration of response was 10.2 months. Median PFS was 11.5 months, and median OS was most 20.4 months. So these tumors also sensitive even after giving exposure to chemotherapy. So this is a definitive target to go with the targeted therapy. Next slide. So it shows the promising intracranial activity in patients with brain mets. As we know that 20% of all patients will have brain mets in lung malignancy. So 88.4% patient had intracranial disease control. 66.7% had intracranial response. The median intracranial PFS in the sub 18% population was 20.9 months, and intracranial median duration of response was not reached. So here we can see in the MRI images below that baseline there was a target lesion which was around 11.1 millimeter. At week 6 it started getting faint, and around week 36 the disease was vanished. So there is definitely intracranial response rate was achieved. Next slide. So coming to the efficacy, it was robust. The ORR was 64%. DOR was 20.7 months. PFS was 16.5 months. And the median overall survival in the cohort of Asian population was 32.7 months. Next slide. So in previously treated Asian patient, the overall was 50. Duration of response was 10.8 months. Median PFS was 12 months, and median overall survival was 23.7 months. So a 30% patient which were accrued in this trial had definitive response as per the normal population. Next slide. So coming to the therapeutic escape, that we have now two drugs approved in the various guidelines. Tapmetco, which has a larger patient pool. In capitative, there was a geometry mono one trial which was there. It has 160 patient. So the potential IC50 was 1.7 and 0.13. The brain penetration of Tapmetco was better, around 25%. CNS endpoints and penetration was slightly better than Tapmetco, 88% versus 54%. The dosing is also easy. 225 mg tablet, 2 tablets a day, and there is a one-step dose reduction schedule. In kappa and imatinib, there is a still 4 tablets has to be taken, and there is a two-step dose reduction is there. Otherwise, in efficacy, although in kappa imatinib there was no Asian subgroup analysis was done, so efficacy was also similar, and in overall response rate, the drug fared better, and in first line, second line, both the drugs are comparable except for median OS, which was better in the tapentco arm. Next slide. So this is the bar diagram of both the drug in efficacy in first line and efficacy in second line. So there is slightly better, although it's a cross trial comparison, but the drug is faring better and the responses are better. Next slide. So why we should choose tepotinib? Because it's a largest study. The inclusion was from liquid and tissue biopsy both. The first line and second line, both the data are very well reported and impressive data. It is the only MET inhibitor with once daily dosing, so there is less pill burden to the patient. 25% brain penetration in the brain metastatic patient. and there is a higher brain intracranial disease control rate, and the matched trial first line outcome of tepotinib was 29.71 versus 20.71 in capmatinib, and there is a better dose reduction, and it is recommended by both the guidelines, and probably it is cheaper amongst both the molecule also. Next slide. Next slide. So this is what means we have MET inhibitors available with us, and tepotinib scores slightly better over the capmatinib. Thanks for the patient listening. Over to the organizer.
Thank you, Dr. Jitendra Pelajani, for your nice and wonderful presentation. And now I would like to invite our next speaker, Dr. Navnath Reddy, and he is working at Sri Ganganagar, and he will be speaking on treatment dilemma, monotherapy versus combination treatment in advanced EGFR mutated NSCLC. So good to see you, Dr. Navnath.
Good evening, sir. Hi, I'm Dr. Navneet.
Navneet, okay.
Yes, sir.
Actually, I have given, sorry, my
It's okay, sir.
apology. Yeah, Dr. Navneet. So you belongs to Hyderabad, I guess?
I belong to Tirupati, sir. I belong to Tirupati. So
Okay.
I am working at American Oncology Institute, Sri Ganganagar.
Yeah. So over to you.
Okay, sir. So good evening, all. Today I am going to present maintenance therapy in advanced ovarian carcinoma. So could you show me the slides, please?
Sure, sir. Just a second.
Yeah.
There is some network issue, so they will play a little slow.
So today I'm going to present PARP inhibition as a maintenance and PARP plus bevacizumab as a maintenance. So today we are going to discuss in detail about these both regimens in advanced ovarian carcinoma as a maintenance therapy. Next slide, please. So ovarian cancer is the third most common malignancy in females. In overall, it is the eighth most common malignancy. And for molecular testing, we need to do in all patients with BRCA germline mutation. BRCA, if germline mutation is negative, then we should go for tumor testing for BRCA somatic mutation. If both are negative,
sorry, actually your slides are not visible.
Yes, sir, that's why I'm directly saying.
Tech team, could you please help? Avni, you can start.
Yes, sir. We do.
Yeah, it's okay. Now you can make the full screen. Only the screen is blank actually.
Okay, sir. I'll just ask Sakshi to.
Sir, give me 2 minutes. I'll share.
Okay, it's okay.
How long you are there, Dr. Navneet?
So for the last 1.5 years, I was here only, sir. I joined here in 2024 May.
Okay,
we only started organization here.
So we'll call you sometime in person in Jaipur also for a offline meeting.
Okay, sir. Actually, I was totally alone here, sir. Recently, I attended this Bikaner conference also. Dr. Pankaj Tandia, he organized the conference, hematology.
Yeah. But you did a actually courageous step you have taken. Sri Ganganagar is a very barren kind of the thing in the field of oncology, and you have joined. That's great actually. Almost 600 kilometers away from Jaipur, and the patients.
So it's visible.
Yeah, it's visible. Yeah.
Okay.
So I'm going to start again. So we are going to discuss PARP as a maintenance therapy in advanced ovarian carcinoma, PARP plus bevacizumab. So ovarian carcinoma is the eighth most common malignancy in India. Among females, the third most common malignancy. Next slide, please. So in all ovarian, next slide, please. In all ovarian carcinomas, in high grade, especially serous carcinomas, so HRD, BRCA1 and 2 all associates to be more than 50% of mutation. So in newly diagnosed ovarian carcinoma, we should test for germline testing for BRCA1 and BRCA2 mutation. Suppose if it is negative, then we are going to test somatic mutation in tumor tissue, BRCA1, BRCA2. If both are negative, and we can go for HRD testing. Suppose if tumor is get recurrent, then we are going to test all these molecular testings, BRCA1 and 2, HRD status, MSI, deficient mismatch repair, tumor mutation burden, folate receptor alpha, RET, NTRK gene fusions. Though the guidelines are strongly recommended for doing this BRCA mutation, but we are having only few percentage of population those who are doing BRCA mutation at the diagnosis. So only 30% of the women undergo any genetic testing. Lower testing rates observed among blacks and Hispanic patients compared to white patients. Next slide, please. Next slide, please. Yeah. So this is the treatment protocol of ovarian carcinoma. So patients, those who are at stage 3, if it is resectable, then they are going to do upfront surgery followed by adjuvant chemotherapy. Suppose if it is not resectable, if there is a doubt of having residual disease of more than 1 centimeter, we give neoadjuvant chemotherapy followed by interval cytoreductive surgery followed by adjuvant chemotherapy. So regarding this maintenance therapy, next slide, please. Next slide, please. Yeah. So regarding this maintenance therapy, so we are having this maintenance for the year 2018. Before that, we were not having any maintenance therapy in ovarian carcinoma. We had data in Lance publication regarding cyclin 7. We got this data result in 2015. After that, 2018, there is FDA approval for bevacizumab. So now regarding this maintenance therapy, we are going to discuss two trials. One is solo one and second one is Paola trial. So regarding this solo trial, next slide, please. Yeah. So regarding this solo trial, so this is a phase 3 trial. Here, before starting this trial, we are having only poor prognosis with the stage 3, stage 4 ovarian carcinoma. Only 70% of the patient they were having survival at 10 years. So relapse disease typically incurable, highlighting clinical unmet need. So Solo 1 came and it is showing with 2 years progression-free survival of 48.3% versus 20.5% with the placebo. We started this using this trial and we continued this trial for more over of 7 years. Next slide, please. The inclusion criteria in this Solo 1 trial, it includes stage 3, stage 4 cancer patients, those who underwent upfront surgery or interval cytoreductive surgery. Or once the treatment was completed, they were randomized into 2:1 ratio with olaparib 300 milligram BD and placebo. So these data they analyzed for 7 years. The primary endpoint of 2 years progression-free survival. Here, median PFS was not reached and not reached with olaparib, and in placebo it was 13.8 months. Updated analysis: median progression-free survival 56 months with olaparib versus 13.8 months with placebo. The aim for the study was studied up to 7 years. Next slide, please. Next slide. The patient characteristics in both the arms were almost similar. So upfront cytoreductive surgery percentage in residual disease percentage is 23%, in olaparib and placebo it is 25%, no residual disease 76% and 72% in placebo. Regarding this mutation analysis, BRCA1 mutation they were having 73% in olaparib and 69% in placebo. BRCA2 25% and placebo it is having 30%. Both the BRCA1 BRCA2 mutations is very less. It is 1.2% in olaparib and 0% in placebo. Next slide, please. Next slide. Yeah. So here previous slide, please. Here they divided patients into high risk group and low risk group. High risk group consists of stage 4 cancer and patients those who are having residual disease after initial cytoreductive surgery and patients those who are having disease after interval cytoreduction. Patients with initial cytoreductive surgery, those who are not having no disease, they were classified as low risk criteria. So primary endpoint after 2 years, here the median progression-free survival with olaparib arm, it is 56% when compared with the placebo, it is 13.8%. Next slide, please. So this is five-year follow-up data of progression-free survival by risk grouping. High risk criteria there. Here the graphs are totally separated, and it is showing clear-cut advantage with olaparibam. And lower risk group, here also the graphs were separated. This is 2 years progression-free survival with median progression-free survival not reached in olaparib, and placebo it is 21 months. Next slide, please. So secondary outcomes, time to subsequent therapy here in olaparib arm it is 64%, whereas in placebo arm it is 41%. Second subsequent therapy it is 62 months in olaparib arm and 36 months in placebo arm. Next slide, please. This is overall survival data. Here the curves are overlapping. It is not showing statistical significant, but here there is a usage of olaparib in the placebo arm as well. So placebo arm use almost 43% of the patients with olaparib, and olaparib arm also they had a usage of 16% with recurrence. Next slide, please. So time from random. Sorry, next slide. Previous slide, please. So time from randomly assigned to second subsequent therapy. Here in olaparib it is 93% and in placebo arm it is 40%. So significant, it is showing significantly there is disease-free survival with this graph. Next slide, please. So this is the safety data. So most of the patients with olaparib they were having grade 3 side effects, 39% when compared with placebo it is 18%. Serious side effects were 20% and 12%. Adverse effects leads to dose interruption. It is 51% of the patient, almost 50% of the patients, and in placebo arm it is 16%. Adverse effects leading to dose reduction it is only 28% when compared to the placebo it is 3%. So we were having a doubt of PARP inhibitors which are going to cause as MDS or AML, but this trial has showed with 7 years follow-up data it is very less when compared with the placebo. It is 1.5, but in placebo it is 0.8%. Next slide, please. So these are the side effects. So nausea and fatigue, this is the most common side effects with olaparib. In order to when compared with the placebo, anemia and neutropenia, these are the most high grade side effects which we see in olaparib when compared with placebo. Next slide, please. So overall summary of the SOLO-1 trial, it is saying that clinically meaningful but not statistically significant overall survival data due to crossover of olaparib in placebo arm, more favorable TSFT and TSST with maintenance olaparib and compared with placebo. No new safety signals discovered. So we conclude that results support use of maintenance olaparib for 2 years to achieve prolonged remission in women with newly diagnosed advanced ovarian carcinoma with BRCA1 BRCA2 mutation. Next slide, please. So we were having data before olaparib with bevacizumab. So maintenance bevacizumab, it is not going to increase significant PFS with single bevacizumab. Then we had a thought that using PARP inhibitors in BRCA1 or HRD mutations along with bevacizumab. Then we conducted PAVOLA trial. Next slide, please. So PAVOLA trial. So it mainly used along with the olaparib. Here, significant PFS benefit observed with olaparib and bevacizumab when compared with placebo plus bevacizumab. Overall, hazard risk is 0.59%. In patients with HRD positive tumors, hazard risk is 0.33. So current final analysis suggests to assess any overall survival advantage at 5 years of olaparib plus bevacizumab versus placebo plus bevacizumab based on observed PFS advantage in primary analysis. Next slide, please. So this PAVOLA study is designed. Here it is designed patients with cytoreduction are neoadjuvant followed by interval cytoreduction followed by plus or minus bevacizumab. Here the randomization was started after 7 months from the first day of first cycle of chemotherapy. In the experimental arm, olaparib and bevacizumab they used, and in placebo plus bevacizumab is using control arm. So this trial they initially conducted for 2 years. Next slide, please. So in this trial, almost 50% of the patient they are having HRD deficiency or mutations. So this is the patient characteristics in experimental arm. Stage 3 is 70%, 69% in stage 3 for control arm. And HRD status, HRD positive almost 47%, here 49% in placebo. BRCA mutation 29, 30%. HRD negative 53%, 51%. So HRD negative irrespective of unidentified HRD status. This is 36%, 32%. Next slide, please. So this is progression-free survival. Here, progression-free PFS for 2 years is 22%, 22 months with olaparib and bevacizumab when compared with placebo beva 16 months. Next slide, please. So BRCA mutation positive patient, they are having a progression-free survival of 37 months when compared with placebo beva 21 months. And BRCA wild type, so PFS it is 18 months and 16 months. This is almost comparable. This is not having any significant data. HRD positive patient, they're having a PFS of 37 months and in control till 11 months. HRD positive excluding tumor mutation BRCA, PFS is 28 months and 16 months in placebo. HRD negative or unknown status, PFS is 16 months and 16 months in both the arms. Next slide. So Pavel, approximately 50 patients they were having HRD positive as we discussed in previous slides. Next slide, please. So this is subgrouping analysis in HRD positive patients, including tumor mutation BRCA positive. So the overall progression-free survival is 37 months, and in placebo it is 17 months. And HRD positive, excluding tumor mutation BRCA mutation positive, here it is 28 months and 16 months. HRD negative patients, the median progression-free survival is 16.9 and 16 months. It is not statistically significant. Next slide, please. So this is the same data in non-BRCA mutation patients. Here the curves are almost overlapping. Hence it is not showing any significant advantage using with olaparib in non-BRCA mutant patients. Next slide, please. So non-BRCA PFS by HRD status. So in HRD positive non-BRCA patient, the curves are separating, and the PFS advantage here it is 28 months, but in placebo plus BY it is 17 months. HRD negative unknown status, it is 16 months in both the arms. Next slide, please. So non-BRCA PFS will be clinical risk. So here the graphs are separated, and in high risk group, the median progression-free survival it is 20 months, and in lower risk group is 14 months. But when compared with in lower risk criteria, so median progression-free survival is 39 months, and in placebo it is 22 months. Next slide, please. So the final PFS in HRD positive subgroups. So 5-year progression-free survival in olaparib plus bevacizumab, it is 46 months, and Biva alone is 19 months. Next slide, please. Overall survival data. It is the curves are almost same. Here the placebo arm, 40% of the patient they used olaparib and bevacizumab, whereas in experimental arm, 90% of the patient they used olaparib. That's why the results are overlapping. Next slide, please. So overall survival HRD positive subgrouping. So here 5 years data it is showing as median progression-free survival in Ola plus Bev it is 75 months, but in placebo and Bev it is 57 months. Next slide, please. The 5-year overall survival data in Ola plus bevacizumab is 73 months, and in bevacizumab alone group is 53 months. HRD positive excluding BRCA mutation patients, overall survival data 54 months and 44 months. HRD negative patients, 5-year survival data is 25 months and 32 months. Next slide, please. So patients regarding quality of life in both the arms are having comparable quality of life. Next slide, please. Regarding adverse effects, MDS and AML at 5 years overall survival, the percentage is 1.7% in Vola and bevacizumab, and bevacizumab only group it is 2.2%. So this slide shows that the risk of MDS in patients with olaparib is also very minimal. Next slide, please. So overall, in summary, the patients with HRD mutation positive, they were having overall survival advantage with olaparib and bevacizumab when compared with bevacizumab alone. In subgrouping analysis, patients those who were not having BRCA mutation and HRD negative, they were having comparable results with bevacizumab alone. So hence, based on this data, we can say that olaparib and bevacizumab we can use in HRD positive patients when compared with HRD negative patients. Next slide, please. So this is newly designed study. Patients also having germline and somatic mutations, VOLA and bevacizumab. HRD positive VOLA and bevacizumab. Non-BRCA HRD positive, we can use VOLA and bevacizumab. Next slide, please. So based on this study, we can exclude VOLA parib and continue. We can continue bevacizumab in patients those are not having HRD positivity. Thank you.
Thank you, Dr. Namrit Reddy, for your nice talk. Now I would invite our next speaker, and she's the last one, and she will be speaking on treatment dilemma, monotherapy versus combination treatment in advanced EGFR mutated NSCLC.
Thank you, sir. Bye.
Thank you. You're welcome.
Hello.
Yes, Dr. Neha.
Good evening.
Good evening. Good evening.
Can we start, sir?
Yes, please.
Avni, can you share?
Sure, ma'am. Just a second.
So the slides are provided by AstraZeneca. So we are talking about monotherapy versus combination treatment in advanced EGFR mutation, NSCLC. Next slide, please. So we'll discuss the burden of EGFR mutation, NSCLC, risk factors or poor prognostic factors, challenges in progression with monotherapy, and head-to-head comparison of mono versus combination. Next slide. So, as we all know, EGFR mutations are observed in almost 40% of patients with NSCLC and Asian group and 20% in non-Asian population. So, the incident rate of EGFR mutations among Indian patients is approximately 40%. And if EGFR mutations are located in the tyrosine kinase domain and result in increased kinase activity of EGFR, and that leads to continued proliferation. So most common EGFR mutations are deletion in exon 19, that is around 50%, and exon 21 L858R point mutation, that is around 25%. Next slide. So, current outcomes with TKIs, like the median PFS in by using different generations of TKI, like gefitinib, erlotinib, the first generation TKI, the PFS around 9.5 months with gefitinib, 13 months with erlotinib, and in second generation, we can see with afatinib and tecometinib, it is around 11 and 14.7 months. With third generation TKI, that is osimertinib, the PFS, reported PFS is around 18.9 months. Next slide. So the topic of discussion is combination of TKI with chemotherapy. So combining this cytotoxic chemotherapy with an EGFR TKI. So this combination acts synergistically by inducing apoptosis and suppressing AKT and extracellular signal regulated kinase phosphorylation, which may delay resistance. So oral TKI decreases the thymidylate synthase level, which may enhance pemetrexed efficacy. So this is the rationale. Next slide. So these all the trials, the early generation TKI is combined with are combined with chemotherapy. These all the trials have shown the shown benefit in the PFS and OS. Next slide. So the FLORA-2 trial, the trial was designed to compare monotherapy with osimertinib versus the combination of osimertinib with chemotherapy. So the patients were included in this trial were untreated locally advanced or metastatic EGFR mutated NSCLC, age more than 18 years, a pathologically confirmed non-squamous NSCLC, exon 19 deletion or 858R, L858R mutation positive, PS score 0 or 1, no prior systemic therapy for advanced NSCLC, and a stable CNS metastasis were allowed, like they don't need dexamethasone or symptomatic treatment, and brain scans and at the baseline were included. So stratification was done by the race, Chinese Asian, non-Chinese Asian or non-Asian, EGFR mutations, and PS score. So they randomized the population in chemotherapy with osimertinib, followed by osimertinib maintenance with pemetrexed versus osimertinib alone. So the primary endpoint was PFS, and the secondary endpoints were OS, ORR, and that health-related quality of life and safety. Next slide. So the baseline characteristics were matching across both the arms, and 40% of patients having CNS metastasis in both the arms. Next slide. So the progression-free survivor, as per investigator, in combination arm, the median PFS was reported is 25.5 month, and with monotherapy, it is 16.7 month. So median PFS improved by around 8.8 months with the combination therapy. Next slide. So progression-free survivor as per BICR. So the combination, the median PFS is 29.4 month, and with monotherapy, it is 19.9 month. So median PFS improved by 9.5 months with combination therapy. Next slide. So PFS, as per investigator across all the subgroups. So the PFS benefit was consistent across all the predefined subgroups, like the EGFR testing, the WHO score, CNS status as at the baseline. All the subgroups have benefit with combination. Next slide. So the PFS with or without CNS metastasis. With CNS metastasis, the combination reported PFS 24.9 months versus monotherapy 13.8 months. And without CNS metastasis, it is with combination 27.6 months, and with monotherapy, it is 21 months. So patient with CNS metastasis had without CNS metastasis had more means increased PFS. Next slide. So by EGFR mutation in exon 19 deletion in L858R mutation, in both mutations, the combination was superior within exon 19.8, exon 19.8 deletion. The combination showed a 27.9 month PFS, and in L858R mutation, the combination showed 24.7 month PFS. Next slide. So the second interim was OS analysis, and the median OS was not reached, and with overall maturity with 41%, the overall median follow-up overall survival with combination 31.7 months versus monotherapy 30.5 months. So OS, it is showing overall survival benefit also. Next slide. So these are the different kind of resistant mechanism which are acquired after the treatment. So the treatment with combination did not affect the resistance mechanism, and it remained similar across the FLORA and FLORA-2 trial. In FLORA, where it has used the monotherapy, in FLORA-2 in both the arms with chemotherapy and alone without chemotherapy. These both the arms and all these three things were showed the same kind of resistant mechanism. Next slide. Safety summary. So all grade 3 or more events was around 64% in combination arm, and with 48% discontinuation, and these are mostly attributable due to chemotherapy, because these mostly are hematological. Next slide. So the most common adverse events in combination arm was myelosuppression, like anemia, neutropenia, thrombocytopenia. So these are due to chemotherapy, and in monotherapy arm, the diarrhea was the most common side effect. Next slide. Safety profile of other combination trials also in in NEJ 009 trial, which combined gefitinib with chemotherapy. So there also grade 3 events are mostly hematological. In TMH study, there are also hematological side effects are more, and in FLORA 2, which in combined osimertinib with chemotherapy, these also they in this trial also the side effects are more with hematological, and these all are attributable due to chemotherapy. Next slide. So a comparison between monotherapy and combination therapy. So in FLORA 2, it showed improved PFS in all comers. So and in CNS metastasis, improved CNS benefit, and it showed improved benefit in both the mutations. Next slide. So newer treatment options for EGFR mutation NSCLC, like we are having osimertinib alone or in combination with chemotherapy, and other newer agent is amivantamab with lazertinib. Also in second lines, multiple ADCs are lined up, and with amivantamab, the chemotherapy alone, chemotherapy or alone the amivantamab with lazertinib, and in also third line. So these are the newer options coming up in the NSCLC. Next slide. So what is the future? So we can see the future with ctDNA. So will ctDNA monitoring guide to choose better treatment options? So this is the risk adaptive trial design. Example is EGFR Shaders trial. So in this trial, they have used the osimertinib given for 3 weeks. Then ctDNA assessment was done. If ctDNA is present, then they have added the additional therapy like chemotherapy or amivantamab versus osimertinib alone. And in ctDNA negative, they continued the osimertinib. So this study will answer that if will high patient with the patient with high tumor burden load will be benefited more with addition of other therapies, and it will be easier to choose patients who will have maximum benefit with the combination. So we can have more tailored approach with this trial, and that can be answered. Next slide. So summary, and so osimertinib in combination with platinum pemetrexed has demonstrated a statistically significant and clinically meaningful improvement in PFS compared to osimertinib monotherapy in patients with EGFR mutated advanced NSCLC with hazard ratio of 0.62. Investigator assessed median PFS was 25.5 versus 16.7 month, and with improvement of 8.8 month, and BICR assessed median PFS is 29.4 months versus 19.9 months. The improvement is around approximately by 9.5 months. So additional benefit is seen with CNS metastasis and with L858R mutations. So and the safety profile were as expected for each treatment and were manageable with standard medical practice. The frequency and severity of adverse events in platinum combination arm were highest during the that platinum based doublet induction chemotherapy with a subsequent meaningful reduction over the time. So the events were attributable to the chemotherapy only. Next slide. So thank you.
Thank you, Dr. Neha. It was a nice presentation. Thank you very much for joining us. And now I would end this webinar. And I would like to thank all the participants, all the presenters, all the speakers, and the moderators, and our media partners and academic partners. AstraZeneca, Dr. Reddy's, Glenmark, GSK, Merck, Zydus, Alkem, Lupin, Sun, Stents. And thanks Team Horizon for making this event successful. Onco Forum 2025, and tomorrow also we will meet with some newer topics. Today we largely discussed about the lung cancer on the various aspect, role of the surgery, role of the radiotherapy, perioperative chemotherapy, and the newer molecules, immunotherapy, and the other things. So thank you very much for joining us, and now we will leave the webinar. Thank you very much and good night. We'll see you all the participants tomorrow also, and I would request to join in time. Thank you very much.
दो 2022 में मेरा गले का ऑपरेशन हुआ था। उसके बाद में मुझे रेडिएशन दिया गया। उसके बाद आज करीब 3.5 साल हो गए, किंतु मैं कुछ भी खा पाने में लगभग असमर्थ हूँ। और जो गाल की सर्जरी हुई साइड में, उसमें और गले की सर्जरी में बहुत ज्यादा दर्द रहता है। अगर कोई समाधान हो तो बताएं।